Hello, my name is Dr. Arinze Ikeme, or some people call me Ikeme. I am a hospitalist and nephrologist in North Carolina, here in the U.S. I am also a teacher. I'm an associate professor with Campbell University, and I teach medical students in different capacities. And so today I want to talk about history and physical examination. And then I'm going to touch a bit at the end on your daily progress notes. And this is really for medical students and also for new physicians. A good history and physical examination, especially your history, tells a lot about your organization and your attention to details as a physician. And it goes a long way in helping you manage patients. And anyone who comes and reads your history and physical examination can usually see where you're going to, what you're thinking. And so being able to learn this skill and reproduce it is a very major hurdle in becoming a physician. And for new physicians who are finishing their residency and they are going to be working in the inpatient setting, being able to produce a good history and document it in the electronic medical records is also plausible. It's a skill you definitely need. So let's just jump right into that and discuss further. So my outline, I'm going to talk about the primary purpose of history taking. I'm going to talk about the components of history and physical exam. I'm going to go into the art and the science of obtaining history from patients. I'm going to talk about the oral and written presentation. I'm going to get really practical with examples of history and physical examination. And then, of course, as I said at the end, I'm going to talk a bit about how you present follow-up visits for inpatients to your attendings. So the primary purpose of history taking is, patient presents at the hospital with a condition causing them distress and anxiety sometimes. And they are expecting you as the healthcare provider to figure out what's going on and fix it. That's at the most basic level. That's really what it is. And so your history taking in its basic form helps the provider obtain enough information from the patient in order to formulate a likely diagnosis that will guide treatment, by adopting the skills learned, in training. And the information obtained from the patient includes the symptoms. That's what the patient will tell you, what they feel, how it started, the character, how it progressed. That's what the patient will tell you. And then you will examine the patient and look for signs, so that by the time you combine the symptoms and the signs, you have a working diagnosis, and then you can get some labs, some images that might help you, narrow down to the diagnosis. And once you have the diagnosis, the treatment is pretty easier. It also creates an opportunity for you to know the patient's underlying clinical health problems and understand how the ongoing issue may be related to or impacted by their overall health condition. This is very important because seeing the bigger picture always helps. It also provides basic information that will guide other healthcare providers like the specialists, the nurses, other ancillary staff that may later be involved in the patient care. So everyone is depending on your history. Everybody looks back at the history, at least most people do. And so you want to have a really good grip on the history you obtain from the patient. So the components of your clinical history would include the presenting complaint, which you should narrow down to not more than 2 presenting complaints, and the history of present illness. So the history, the story surrounding the presenting complaint, which is where I'm going to dwell on. And then, of course, you have your past medical history, occasionally the psychiatric and the gynecological history, the past surgical history, the social history, your family history, your allergy history, current home medications, review of system, etc. And then, of course, your physical exam, the vital signs, your general impression of the patient, the CNS exam, the head, eye, ear, nose, throat examination, or the neck, the cardiovascular system, respiratory system, abdominal exam, urogenital system exams, and the extremities and the skin. So the components of the history of present illness should include and reflect the course. Okay, so that's usually the story the patient tells you. Again, I'm going to say this is very comprehensive, and this is going to give you a comprehensive history of present illness and put everything in together that you need. Occasionally, this is all most people will read. They won't read the past medical or the past surgical history. So, getting the history of present illness as buffered, as complete as possible is important. So, but this is my recommendation, and I'm sure people will have different ways they present theirs, but this is pretty comprehensive and can be a good presentation wherever you are in the world. So, the course, the story, how did it start, the duration, how did it progress, the character of symptoms. So if they mention symptoms, what can they tell you about those symptoms? There are symptoms you can characterize like pain. Where is it located? How do you describe it? Any radiation, aggravating, relieving factors. And then the cause. You should be able to ask questions that will reflect that you're trying to figure out the cause of the presenting complaint. And we'll go into that in details. And then, of course, associated symptoms, which are a combination of symptoms that can often point to a diagnosis. And when you're talking about associated symptoms, they are usually all within the same system. And that's where you review the system that's related to the presenting complaint as associated symptoms. Of course, the treatment prior to presentation, have they done anything? Have they seen a doctor? What was done? And then I usually leave a paragraph that gives a background history related to the presenting symptoms, like prior episodes or evaluations. For instance, someone comes in with a chest pain. I give a paragraph after I've reviewed what's going on and possible causes, treatment so far. I leave a paragraph to talk about whether they had any cardiac catheterization recently, a stress test recently, and for GI bleeds, whether they had a recent upper endoscopy, lower endoscopy, stuff like that. Things that add meat and flavor and actually a lot of information to your history of present illness. And you need a combination of your art in medicine and science to obtain this information. So let's talk about the art and science of obtaining history from a patient. The art. Okay, people always say medicine is an art and is also a science. So let's talk about the art. It involves your approach to achieving success with obtaining the information that you need from the patient. How do you go about it? What's your initial impression? Your interviewing process and skills, your ability to prioritize information received from the patients, your ability to redirect patients when they get distracted. How do you do that? Being able to do this is an art, okay? And the science is, of course, your knowledge in medicine directs the questions you ask as you review different diagnoses in relation to the presenting complaint, and you appreciate other factors that might contribute to the ongoing illness. And this is based on what you know. What you know expands your differential diagnosis when you're interviewing patients. So again, the art is important. Your initial impression, your dressing, how you present. I've often seen physicians walk into patients' rooms wearing jeans and t-shirts, and while one needs to be comfortable, I would recommend formal dressing or scrubs at least. And initial greeting, your respectfulness, your being polite, acknowledging family members or chaperones, your sensitivity to the patient's needs. A patient, you might walk into the room and they tell you they've been asking for a cup of water, and you just want to go on and talk about what's going on. But just helping them get that cup of water might actually make the experience more pleasant for the patient and for you too. And then I usually say start with open-ended questions like, ask the patient, what brings you to the hospital today? It gives them a chance to tell you their story. Again, we talked about the course, COURSE. How did it happen? What happened? So when you say what brings you to the hospital, they tell you the story, and it gives them a sense of being heard. And I know it demands a lot of patience for providers who are in a hurry to jump to the next patient, but you have to hear the patient out. It gives the healthcare provider a fairly good picture of what is going on when you hear the story. And then after you stay with open-ended questions, then you can move on to close-ended questions as you obtain more information on the symptoms, including the character, the duration, and associated symptoms. Again, these are answers that will be guided by your questions. Sometimes the patients don't know what will help you, make a diagnosis. And so being able to ask about, the pain you had, was it a dull pain or a sharp pain? Did it come on suddenly? Reviewing systems associated with the presenting complaint is a good way to narrow down your differential. And you can direct the questions to help figure out possible causes. For instance, being able to review systems like asking the patient, okay, with the nausea and the vomiting, was there diarrhea too? Was there fever associated? Was there abdominal distension? Was there abdominal pain? So even though they are all related to the same gastrointestinal system, the addition of diarrhea to nausea and vomiting with fever seems to suggest maybe a viral gastroenteritis or an infection. And in nausea and vomiting with abdominal distension, it can, make you suspect things like abdominal obstruction. So again, you're reviewing the system related to that particular presenting complaint, yet it's helping you figure out the possible causes. Okay, another thing is redirection. Sometimes patients deviate from questions being asked and they, go into other things that might be bothering them, and you should have a polite way of bringing them back to the ongoing issue. And you need to do that respectfully, of course. And then, of course, at the end of the discussion, again, this is the art that helps. This is not, based on your knowledge of medicine. This is the art. Discussing your differential diagnosis with the patients, what you plan, the tests you plan to do, what the treatment plan is, whether they are going to be admitted or they are going to be discharged from the ER. It's all important. So you want to let them know what the plan is. And this is part of the art of medicine. So what about the science? As I said, you need a good knowledge base of your clinical sciences and differential diagnoses for different presenting complaints, because they go a long way in directing some of those close-ended questions. Like you can ask about, if you're thinking of a tick bite symptom, you can ask about recent hiking, camping, travels, and you need to have a foreknowledge of those conditions and how they present. Being able to localize the system involved based on the presenting complaint can also guide your questions. And this is the science of medicine. So if someone comes in with nausea and vomiting, it could be gastrointestinal, could be genitourinary system. If they come in with shortness of breath, you're thinking cardiovascular or the respiratory system. If there's a unilateral limb weakness, you're thinking brain, spinal cord, etc. So being able to localize the system involved does help you, and this is part of your science as a doctor or a provider. Okay, let's go to the practical aspect of it, the oral or the written presentation of your history and physical. Again, everyone does things differently, but this is one of if you want to have a comprehensive history of present illness, this is the way that I would recommend. There's a first paragraph that talks about introducing the patient's age and the past medical history that's really important with the presenting complaint. For instance, introductions like 45-year-old male with history of congestive heart failure presents with worsening shortness of breath. Okay, so you have that opening statement, and you don't have to write 45-year-old male with history of diabetes mellitus, hypertension, gastroesophageal reflux disease, hyperlipidemia, adrenal insufficiency. You don't need to present all that. You can pick one or two that affects or that are related to the presenting complaint. As I said, history of congestive heart failure and COPD presenting with shortness of breath. And then you go on to, and you can see this particular page, I color coded it because I'm going to be addressing different parts of your history of present illness. And so I give them different color codes. And I do hope the colors are clear. So in that first paragraph, you want to introduce the patient and what the presenting complaint is. And when immediately you do that, you want to go into the story. Okay, that's the course, and characterize symptoms that can be characterized. So you want to, it's in the course that they tell you, that's the number one. They tell you how it started, whether it progressed, all the symptoms involved. And you also want to reflect the cause, potential causes, and the best way to address the potential causes in asking the patient is one, reviewing the system involved in the presenting complaint. Okay, as I said, if you say nausea, vomiting, and you say there was diarrhea with fever, everyone thinks gastroenteritis or some kind of infectious process. If you say nausea, vomiting, no diarrhea, but abdominal distension, one can think of abdominal obstruction. If you say nausea, bloody emesis, and epigastric pain, one can think of a GI bleed, maybe a peptic ulcer disease or some kind of hemorrhagic gastritis. So you can see that just by introducing the systems, reviewing the systems related to the presenting complaint, that can help you narrow down a cause. But in addition to that, if you look at the yellow characters, on this particular slide, where I mentioned takes ibuprofen 3 times a day and BC powder for headaches, but not on anticoagulation or other antiplatelets. You can see that even though these are not review of systems, they are also trying to figure out the cause of this patient who has nausea and bloody emesis. So they are trying to figure out if there are other variables that could have caused the bleeding. And so that's why the yellow one mentions the ibuprofen. So again, in the first paragraph, you introduce the patient, the presenting complaint. Then you mention you discuss the story, the cause, and then show the cause, the possible causes, CAUSE, by reviewing the systems related to the presenting complaint and then other possible causes. And then when you finish all that together, the second paragraph I always encourage is find out if there's any background history related to the current problems. For instance, patient is coming in with upper GI bleed. Have they ever had an upper endoscopy before, and what did they find? Okay, you can ask the patient this, but this also forces you to look back in the electronic medical record to see if something like this has happened before and what was done. Again, the goal is to know what's going on with the patient, have a good tentative diagnosis, but have a big picture on what's going on. So I usually try to encourage you to add that background history as a second paragraph. And then the optional third paragraph, some people like this. I like it. Some people don't. Some people prefer to put it right at the end. What happened in the ER? So in this case, I mentioned at the ER, the vital signs were stable. Hemoglobin was 7.6 grams from 13 grams just 2 months ago. CT abdomen was negative. He was typed and screened, given some IV fluids and starting on proton pump inhibitors. So again, this is a practical, detailed component of your history of present illness. And I'm going to give us some examples. So again, look at the color codes, the introduction, the blue lettering that discusses the story and the possible causes where you review system and think of other, and then the yellow one, the yellow character that discusses other possible causes, and then the second paragraph, which is in green, that talks about a background history, and of course your ER experience, what happened in the ER. And some attendings actually just want to hear the HPI, the history of present illness, and then go to your examination and your assessment and plan. So having a really comprehensive, detailed, HPI does help. So let's look at a sample of history of present illness and let's go through those components we talked about. So this says 50-year-old female with history of congestive heart failure and COPD presents at the ER with worsening shortness of breath. So you can see how the background past medical history mentioned are ones that are related with the presenting complaint, which is shortness of breath. It says worsening shortness of breath for the past 1 week. She first noticed she was short of breath after taking her usual daily walk a week ago, which was unusual. She denied any chest pain or palpitations, but noticed some bilateral leg and abdominal swelling, as well as a 5-pound weight gain, which has worsened over the past week, as well as PND and orthopnea. No associated cough pain. She had some dry cough, but no rhinorrhea, nasal congestion, sore throat, no wheezing or fever. For the past 2 days, she has started experiencing the shortness of breath even while resting, and so came to the ER for evaluation. So this is the story. Okay, so you can see if you look at the blue characters that I've written so far, you can see the shortness of breath. You can see me trying to figure out the possible causes, because again, I'm thinking this is either cardiovascular or respiratory, since it's shortness of breath. So I reviewed the systems related to cardiovascular by saying that there was no chest pain, no palpitations, but there was some weight gain, some PND, some orthopnea, no calf pain. Anyone listening to this knows, wow, it's sounding like a heart failure, because there is PND, there is orthopnea, but there is no chest pain, there is no palpitation. So the cardiovascular system review of system was included, introducing the positives and the negatives. So the negatives are also important as well as the positives. But since I had to accommodate for respiratory problems also, I had to mention that there was some dry cough, but there was no rhinorrhea, no nasal congestion, no sore throat, no wheezing. Anyone listening to that knows I'm looking through the respiratory system. And of course, you can see both the story, the possible causes involved, and how they presented at the emergency room. So then, other possible causes of the presenting complaint. Okay, so while I've narrowed down, the yellow characters are going to say a little more on possible causes of this presentation. So she claims compliance with her diuretics and has been on Lasix 40 milligrams daily with no recent dose changes. She denied any dietary indiscretion and has restricted her fluid intake as instructed. She, however, admits that her blood pressure has been elevated, with systolic blood pressure often more than 170, despite compliance with her medication. So again, looking at this, you can see me trying to assess, since it's tending towards cardiovascular, you can see me looking a little bit more in what could have gotten her to this stage, what could have caused this. So reviewing her compliance with her diuretics, how much diuretic she's supposed to be on, dietary discretion or indiscretion, fluid restrictions, and blood pressures being high can trigger congestive heart failure. So you can see me reviewing the other possible causes beyond just the review of system in this history of presenting illness. So let's go even a little further. So then I give a background history in the green characters. Okay, it's another paragraph, and I mentioned she had her last echocardiogram done last year, and ejection fraction was reported at 30% with moderate aortic stenosis and mild pulmonary hypertension, with reported pulmonary arterial systolic pressure of 50 millimeters mercury. Her last cardiac catheterization was also done last year with no coronary artery disease. This gives a little bit of background to that congestive heart failure, her cardiac history. And you can see, getting this information so far, it's beginning to take shape. You're getting the bigger picture on this patient. Anyone can tell she has a cardiomyopathy and she's coming in with congestive heart failure, and her blood pressures hasn't been well controlled. Okay, again, the goal is to get the big picture, know what's going on, so that you know how to target your treatment on this patient. So again, this is the optional paragraph where you mention at the ER, the blood pressure was elevated, 185/110, with heart rate 92 beats per minute. Oxygen saturation was 92% on room air. Troponin was normal with BNP 1200. Chest X-ray reported evidence of congestive heart failure. She was given a dose of IV Lasix, 40 milligrams, and admitted for further evaluation of acute decompensated systolic heart failure. So you can see the breakdown as I went through the course, which is the story, the possible causes, additional possible causes, the background history, and what happened in the ER. And let me give another sample. Okay. So this is 62-year-old male with a history of gastroesophageal reflux disease, presents at the ER with nausea and bloody emesis ongoing for 3 days. So the mention of a history of gastroesophageal reflux disease was used because the presentation was the nausea and bloody emesis that was related to GI. He had eaten at a local restaurant with his spouse the night before. By the next morning, he started feeling very nauseous with subsequent vomiting of coffee ground emesis associated with upper abdominal sharp pain radiating to the back, but no abdominal distension, diarrhea, or fever. He has been taking some Tums he bought over the counter with no relief and has not been able to tolerate any food or his oral medication. Symptoms have persisted for 3 days with generalized weakness and dizziness, and so he came to the ER. So this gives you a story. You can imagine he went to eat somewhere and he's there having this nausea, vomiting with blood. Okay, and this is the story so far. This has gone on for 3 days. Looking at these, you can see that there is a review of GI system on that paragraph. There is a mention of abdominal pain, characterizing the abdominal pain as sharp and radiating to the back, mentioning abdominal distension that there was none. So it was an important negative to mention. There was no diarrhea, there was no fever. Was important to mention because these are all GI review of system. And you can see the treatment he's done so far didn't help, and so he came to the ER. So this gives you a good picture of what brought him to the hospital. So this is the course, COURSE. Okay, and then we go into other possible causes. Okay, he's not aware of any sick contacts, and spouse doesn't seem to be having similar symptoms. Okay, he admits to taking ibuprofen, 4 tablets 3 times a day for low back pain, and uses BC powder a few times daily for headaches. He's not on any anticoagulants or other antiplatelets and has no bleeding disorder. So again, this is showing other possible causes of this upper GI bleed. His use of ibuprofen might be contributing, the use of BC powder, which, just in case you don't know, sometimes will have up to 600, 800 milligrams of aspirin, pretty high dose of aspirin, that can cause gastric ulcers or bleed. And so you can see me trying to look at other possible causes of his presenting complaints of nausea and bloody emesis. Okay, and that's in yellow character. So then I give a background in green character. A background, he has had upper GI bleeding in the past and had an upper endoscopy done 3 years ago with a bleeding duodenal ulcer, but has been out of his proton pump inhibitor for years. Okay, that background history is definitely important with what's going on right now. That gives us a clue at what this might be, since this has happened before. And of course, the optional fourth paragraph at the ER, he was afebrile, blood pressure was stable, slightly tachycardic, WBC was normal, hemoglobin was 7.5 grams, a drop from 13 grams 2 months ago. CT abdomen was unremarkable. He was typed and screened, given some IV fluids, started on proton pump inhibitors, and admitted for further evaluation of his upper GI bleeding. Again, this is the breakdown. So, of course, after the past medical history, after the history of present illness, where I spent my time, you still have to go through your past medical history, past surgical history, social history, family history, allergy history, home medications, review of system, and of course, your physical examinations, your lab results, your imaging results, and then your assessment and plan. But, I haven't spent time in these other history aspects just because these are ones that you can just pretty much ask the patient. You don't need to think too much. You don't need to exhibit much of arts or science in that. You just need to get information from the patient to fill in the blanks. And then you have your assessment and plan. So let's shift gears and talk a bit about the daily progress report or follow-up presentation. So you're in the hospital, you're doing your residency, or you're a medical student in your rotation, and you want to, you're seeing you're following up on a patient, and you want to present to your attending or your consultant. I would say for patients already admitted in the hospital, daily progress notes will need to be given to the attending during clinical rotations as a med student or your residency. And it should be brief, straight to the point, and yet provide clarity for further management of the patient. As a resident or a medical student, you should assume that the other medical students or residents around do not really know the patient and should be able to grasp the condition being managed from your presentation and the treatment modality, so they can learn and be part of the management and also know the goals for discharge readiness. So how do you do that? The format, the diagnosis and then the sub format. So you state the diagnosis and then the format. So I usually would say state the formal diagnosis immediately. So example, Mr. X is a 60-year-old male being managed for sepsis due to right-sided pneumonia. Or you say Mrs. G is a 56-year-old female being managed for upper GI bleed. This is not a time to say 60-year-old male who presented with some cough and shot. That's your history of presenting illness. When you're presenting a history for progress notes, state the diagnosis so everybody knows what's going on with the patient. Sepsis due to right-sided pneumonia or upper GI bleed. Then you start your subjective, any events throughout the night, any updates, any new complaints. You can review system, but you can abbreviate the system, by just asking for specific ones like any nausea, vomiting, any diarrhea, any chest pain, shortness of breath. So you pretty much just hear the patient out if there's any new complaint. Then your objective is your vital signs, your complete physical examination, and spend more time on the system involved. For instance, if they had a stroke, a more thorough CNS exam is expected. If it's a GI bleed, a more thorough GI examination is expected. If it's a COPD exacerbation, again, respiratory system examination should be emphasized, And then your assessment and plan, just state clearly what is being done for the working diagnosis and then other conditions that are being managed and what our goal is or your goal is to discharge these patients. That's pretty much the format that you use. Okay, so I'm hoping that this would be a good guide. Again, I know people do things differently, but this would be a good guide for those who need a little bit more detail in how to present their history of presenting illness or their daily progress notes. I'm hoping this was helpful in this case. Thank you.